Thanks so much, everyone, for joining us today. Hopefully you've been enjoying the nicer weather and the sun recently these past couple of days. We've got an excellent session tonight on tobacco use disorder, going over what pharmacists can do and reviewing some of the latest recommendations and the newest options. We also have a special guest tonight, so you guys get a break from me for the webinar. We have Todd Prochnau, and Todd is a registered pharmacist and community pharmacy owner in Alberta, Canada. He's a certified tobacco educator with extensive experience running a pharmacist-led tobacco cessation clinic. Todd is an accomplished healthcare provider, having his additional prescribing authorization and authorization to administer drugs by injection. Todd is also a strong supporter of the profession of pharmacy and served as a board of director of the Alberta Pharmacists Association from 2012 to 2020 and was president in 2015 and 2019. He is a recipient of the Canadian Pharmacists Association Dean George A. Burbidge Award for receiving the highest mark in the Pharmacy Examining Board of Canada's qualifying exam. Todd is relentless in his pursuit of helping patients reduce the risk of tobacco smoke exposure and is a frequent presenter at meetings and conferences. Thanks so much, Todd, for joining us. We're super excited to have you here and to learn a little bit more about the latest updates. I'll pass it off to you.
All right, awesome. Thanks, Molly, and thanks to everybody for joining and logging on tonight. Looking forward to talking to you about tobacco use, smoking cessation, and kind of all the things that are changing in this area, because we finally do have kind of some new things and some new strategies available to us. So here are our learning objectives. We're going to kind of go over everything related to tobacco use disorder, and probably what will be most relevant is the stuff that is newer, and talk about kind of some of the non-conventional strategies that we have at our disposal now. I have been paid from the following entities. I am being paid as well to present this to you tonight, so I need to disclose that. What I always like to start with when I speak is just touching a bit on the statistics around tobacco use and where we have come from and where we are with things like smoking prevalence in Canada. And also to kind of frame what all the harms are from tobacco use and smoking, because I'm sure you're aware of them. Of course, most people are, especially health providers. But when we start to talk about alternative options and think about things like e-cigarettes or vaping, which more and more people are doing, we want to have a good understanding of what the harms are, and then, of course, how they compare. But let's look at the prevalence first. So I really like the graph on the left-hand side, because this shows us how smoking rates have changed in Canada since the 1960s. And you can see that back in 1965, it was like 50% of Canadians smoked. So, I mean, it was extremely high. You think about that today, and it would just be, almost seem kind of just totally out there, right? But it was the reality. And you can see that over the decades, we've reduced that quite substantially. So then when you look on the right-hand side, by 1999, we were at about 25% for smoking prevalence, all the way down to about 15% by 2017. So as a country, we have made tremendous progress on smoking rates, and we have seen a lot of people be successful in both quitting smoking or just reducing maybe some of the uptake. But what we are seeing is smoking rates are starting to plateau. So you can kind of see on the graph on the right that it's getting harder and harder to decrease that value further. And that's kind of why there's some renewed focus on what some alternative strategies might be. So this is the most recent data we have. 2019 smoking rates were 14%, and in 2020 it was 12.1%. So I mean, there's usually a little bit of fluctuation year to year, and so it was probably like around 13%. So about 13% of Canadians are still smoking at this point. So I also mentioned I like to talk about the health consequences, and it remains that tobacco use is still the single biggest cause of both preventable illness, disability, as well as premature mortality in Canada. So it still is a major public health issue, even with those greatly reduced smoking rates. We know that over half of all lifetime tobacco users will die as a result of the use of tobacco. So if somebody uses tobacco their whole life or their whole adult life, it's essentially a flip of a coin if that will end up killing them or not. And so I like to think of the most notable health consequences is the triple C. So we've got cancer, cardiovascular disease, and then COPD or respiratory disease. Now, what's really important to understand about these health consequences is that they are a result of over 4,000 chemicals that are found in tobacco smoke, and at least 50 of those are known or suspected carcinogens. But these chemicals, for the most part, are produced when tobacco is burned or combusted. So when someone smokes a cigarette, they light that cigarette and it actually results in the burning or combustion of tobacco. And that's where the majority of these chemicals and toxins are produced. So things like carbon monoxide, formaldehyde, and hydrogen cyanide. Nicotine is very highly addictive, but it's not actually the culprit of these main health consequences. So it's what makes people addicted, but not necessarily what's causing the cancer, cardiovascular disease, and COPD. So the other health consequence, of course, to be aware of is secondhand smoke, right? So if you're in the same room as somebody that's smoking, or even just standing next to them on the street, you can breathe in a lot of those same toxins and carcinogens that person that's smoking is going to be experiencing each time they're inhaling. And so it's estimated that about 1% of deaths internationally are actually caused by exposure to secondhand smoke, and rates are higher amongst women. And so secondhand smoke continues to be a major concern as well. For adults, you get much of the same health consequences. So things like cardiovascular disease, some cancers are associated with it, for example. But then there's a lot of negative impacts to children too. So specifically things like SIDS, low birth weight, lots of respiratory issues and those types of things. So although it's ideal if people don't smoke in their homes or their vehicles, it is unfortunately something that does go on. And so there's many Canadians that are still exposed to secondhand smoke. And then the one that people don't always know about is third-hand smoke. And third-hand smoke really just refers to all of those toxins and carcinogens that are found in tobacco smoke will fall down to furniture or flooring or carpeting in a room. And so those toxins and carcinogens just kind of fall into the material on a couch or a carpet, say, and then they can kind of get inhaled or absorbed through the skin of anyone that's, say, sitting on that furniture or walking or crawling on that carpet. And so this is a concern because the risk is really to infants and young children, because they are the ones that spend the largest amount of time on the floor. If you think about crawling or kids playing on the floor. And they also have a higher respiratory rate. So they take more breaths per minute, and that results in a higher exposure too. So third-hand smoke is kind of an additional problem related to secondhand smoke. So that hopefully kind of gives us a basic frame of our discussion as we move forward here. But let's move into tobacco use disorder, and let's talk a little bit about nicotine and why it's so hard to just stop smoking. So we know that nicotine is a stimulant, and it creates a sense of well-being and increase in alertness. And so when somebody takes a puff of a cigarette, it's rapidly delivered to the brain, and within about 5 seconds, it reaches that kind of pleasure reward system in the brain. So that's extremely quick and makes it very highly addictive. And so very quickly, with continued use, the user will experience chemical and biological changes to the brain chemistry that very quickly will create a tolerance and a dependence. Now, nicotine addiction is really broken down into different components, and this is what makes nicotine so hard to stop using once a person is addicted. So there's two kind of I guess, baskets of components that I like to think of. So the first is that physiological or physical addiction. So nicotine causes or creates a pleasure or a high very similar to other psychomotor stimulants. And so it's really not all that different than other stimulants. And it's really just creates that physical dependence. So the physiological addiction is really just that, your nicotine receptors are used to getting that nicotine. And once they don't, a person's going to experience that withdrawal quite quickly. But the second component of this addiction is the psychological, behavioral, social part. And that's where smoking is usually a normal activity for people. So it's part of their normal daily routine. Often people will smoke to deal with stressful situations, and often with family or friends, for example. So it's often a social thing as well. So when someone stops using nicotine, not only do they have to break that whole physical aspect of it, but there's this huge psychological, behavioral, social component that they have to deal with too. And that's really what makes it so difficult. So you might have noticed that the title of tonight's talk has tobacco use disorder in it. And this is a term that we use very purposely because it's really meant to illustrate that addiction to nicotine, addiction to tobacco, is not all that different than addiction to other substances like alcohol, opioids, take whatever other illicit drug. It creates an addiction, much like those other types of addictions. And so tobacco use disorder is actually defined in the DSM-5. So along with other psychiatric illnesses and other addiction illnesses, it is actually in there. So it's just a good reminder for all of us as health providers to just remember that, although often it's viewed as just a bad habit that people should just stop, it's much more than that. And it is an addiction like other addictions. And so within the DSM-5, there is withdrawal diagnostic criteria as well. So it clearly outlines the type of withdrawal people often will experience when they stop using nicotine. So symptoms include things like irritability, frustration, anxiety, trouble concentrating, feeling restless, feeling depressed, insomnia. So all pretty unpleasant things to feel. So you can appreciate how withdrawing from nicotine is pretty uncomfortable. So let's move to the goals of therapy when it comes to tobacco use disorder. So the ultimate goal is pretty obvious, right? We ideally would like to help all people just achieve complete and sustained remission from tobacco use. So ideally, you would just help every patient quit smoking. And that's really the number one goal, and it remains our number one goal. So secondary goals that go along with that are reducing the morbidity and mortality that's related to those different conditions we talked about: cardiovascular disease, cancer, COPD, but also to try to minimize adverse effects from drug therapy that's used for smoking cessation. And then really to just understand, both for ourselves and for the patient, that smoking cessation is a process. It is not a singular event. So most people try many, many times to quit smoking, and it can take a long time to be successful. So really, we just want to try to learn from every quit attempt, whether it's successful or not successful. Now, what we're going to chat about tonight a bit is this intermediate goal. And so this intermediate goal is something that's new in this area. And that's for those patients that are unable or unwilling to quit smoking. And that goal may be to reduce tobacco intake or potentially to switch to an option that's lower on the risk continuum. And so it's kind of like a harm reduction approach, if you think about harm reduction in opioid use disorder, for instance. And so that's largely what we're going to discuss tonight, is how tobacco harm reduction could look in practice. So before we do that, we have to kind of review where we are with treatment. And a lot of this is just that, it's review. So you'll probably find that you probably know these slides pretty well already. Things haven't really changed in the 12 years that I've been a pharmacist. We haven't had really new drug therapies, but it's still helpful to just understand kind of what the most recent evidence is saying. And so the general recommendation is that patients that smoke 10 or 10 more than 10 cigarettes per day and wish to quit should be offered drug therapy. So they could be offered any of the three first line options: nicotine replacement therapy, bupropion, or varenicline. Now, what I always point out is even if a patient smokes less than 10 cigarettes a day, they can still benefit from drug therapy. So there's less evidence for success in this group. But if you think about someone that smokes, say, 5 cigarettes per day, they can still really benefit from using nicotine replacement therapy as needed, just for those breakthrough cravings. So although they might not tolerate the patch or varenicline, for example, they could still benefit from that fast-acting nicotine replacement therapy. So really, any patient that smokes and is quitting could probably use at least some nicotine replacement therapy. Now, the general school of thought is that there's not enough high quality evidence to recommend one first line medication over another. So, between these three first line options, probably one is as good as the other. And it really comes down to patient preference, what they've tried before, things like that. Now, some organizations or some experts, like the American Thoracic Society, do recommend that varenicline is kind of the first line option, or the preferred first line option. And that's mainly because it does have some better data when it comes to efficacy. And so this is the efficacy data of the various first line drug therapies. And so what this chart shows is the odds ratio or risk ratio of essentially what the drug does to increase the odds of quitting. So placebo or no drug therapy would be 1.00. And then the other drugs are going to have a number higher than 1 because they're going to increase the odds of quitting. And so you can see that for nicotine replacement therapy and bupropion, generally the odds ratios are somewhere between 1.5 and 2.0. And so they increase your odds by, somewhere between 1.5 and 2 times. You'll note probably that the mouse spray is higher than 2, but there's a very large confidence interval on that. So really it's not high quality data available there. Likely it's probably closer to the other ones. So you can see that varenicline's odds ratio is a little bit higher at 2.24 than the other options. And there is fairly high quality data there. It's got a pretty tight confidence interval. So it does result in a little bit better efficacy. So let's talk about nicotine replacement therapy first. And nicotine replacement therapy, or NRT, basically just provides the body a clean form of nicotine, right? So it's much the same concept is giving Suboxone or methadone for somebody that is using illicit opioids. It's providing the kind of action at the receptors so the patient doesn't get the withdrawal, but it's a clean form. It doesn't come with all those toxins and carcinogens that are produced when you burn or combust tobacco. And so that's really the concept of nicotine replacement therapy. And of course, we've used it for many years now, and it does have evidence of effectiveness, but it also has limitations. So some patients just find it difficult to kind of get enough nicotine from nicotine replacement therapy, especially if you think about somebody that's a heavier smoker, like say a couple packs per day. One thing that's always, I think, important to discuss as well is how long can you use nicotine replacement therapy? So the standard length of time it's recommended for is 8 to 12 weeks, although there is some data that using nicotine replacement therapy up to 24 weeks can improve cessation rates. Really, though, extending the use beyond 24 weeks, although it has not been demonstrated any additional benefit to success in cessation, it is a reasonable approach in a harm reduction context, right? So if you have a patient that is using nicotine replacement therapy and they've been using it longer than that 24 weeks, if the alternative is going back to smoking cigarettes, then nicotine replacement therapy is a much better choice, right? So, really, this is kind of our first example of where harm reduction can be used and is commonly used when it comes to smoking and tobacco use. So, although nicotine replacement products will say 8 to 12 weeks or sometimes up to 24 weeks, if a patient needs it longer, if it keeps them from smoking, then it's always a better choice because, again, it doesn't come with all of those carcinogens and toxins. So our first prescription option, of course, is bupropion, which we know is an antidepressant that also just happens to work for smoking cessation. Now, how it works is not totally well understood. Likely has to do with the effect bupropion has on dopamine. We know that dopamine is very highly involved with addiction and different addiction pathways in the brain. So likely there, it's having some sort of effect there. The dose, of course, is 150 milligrams daily for 3 days, then 150 twice a day for 7 to 12 weeks. And the quit date is recommended to be within the first 1 to 2 weeks of drug therapy. As far as side effects go for bupropion, insomnia is definitely the most common one. So 30 to 40% of users will actually experience this. And what's recommended if somebody does have it, especially, is to take the first dose in the morning and the second dose 8 hours later. So you're not supposed to take the 2 doses any closer than 8 hours, but some patients will have success by doing kind of one first thing in the morning and then the other one 8 hours later. Other side effects are typically general, so things like dry mouth, constipation, headache, tremor, and increase in blood pressure. And there is no significant increase in any type of psychiatric adverse effects with bupropion. So we're going to talk about that a little bit more when we chat about varenicline in a second. But it's important to note that there have not, or it's kind of been demonstrated that there's no increased risk of things like depression with bupropion. It's obviously an antidepressant, but we know that many antidepressants have that black box warning. And then finally, there's varenicline. So varenicline was the first and is really the only drug that was specifically designed for smoking cessation. So it is what's called a alpha 4 beta 2 nicotinic acetylcholine partial agonist. And so what that means is it's doing two things at those receptors. It's binding at those receptors, which causes a response to a lesser degree than nicotine, but still a response. And what that does is it limits withdrawals. So you're essentially still stimulating the receptor. So the patient doesn't get the withdrawal that they normally would from just stopping nicotine cold turkey. But it also blocks the nicotine from binding. So if somebody does smoke while they're taking varenicline, they often will find smoking is just less rewarding. So patients will sometimes say, I just kind of quit once I started varenicline because it's blocking those receptors from nicotine binding. The dosing is kind of similar to bupropion. So you start slower and lower. So 0.5 milligrams a day for 3 days, then 0.5 twice a day for 4 days, and then 1 milligram twice a day for 11 weeks. And the quit date should be in week 1 to 2 as well. Now, usual treatment is usually 12 weeks, but a total length of up to 24 weeks can be done if required. And it's also useful to know that if the dose of 1 milligram twice a day is not tolerated, the lower dose of 0.5 milligram twice daily still has some evidence for effectiveness. And so it can be another option for patients. Let's talk about the controversies that came with varenicline. So the one that most people are familiar with is the psychiatric controversy. So when varenicline first came to market, there were many case reports of patients experiencing depression or even suicide attempts, suicidal thoughts, all that kind of stuff, that were taking varenicline to try to quit smoking. And so it was given a black box warning back, kind of a couple of years after it came to market, just warning health providers of this possible issue and to, obviously approach it very cautiously. Well, in 2017, a large study called the Eagle study was published. And what this study did is it looked at psychiatric adverse effects in patients taking varenicline, as well as patients taking bupropion. So that's kind of how we know that bupropion doesn't have that increase in psychiatric adverse effects from the Eagle study. But the Eagle study actually demonstrated that varenicline as well does not have an increased risk of psychiatric effects. And so Health Canada has actually removed that warning box on the product monograph. And so that's good news because obviously this is the most effective drug we have for smoking cessation. And because of that, it's nice to know that it doesn't have that increase. Now, what I would always say, though, is anybody that's quitting smoking is really at risk for experiencing depression. And of course, in extreme cases, suicidal thoughts. And the reason for that is because you're taking, rapidly stopping a stimulant that, might have even been used to treat some undiagnosed mental health issues. And so for that reason, it's usually recommended that everybody be made aware of that. So I usually would warn patients about it regardless of what drug they're taking. Is just that, some patients can experience depression or mood changes when they quit smoking. And it's just, important to let a health provider know. Now, the other controversy I put on here is the cardiovascular controversy, much less known about. But in 2011, the FDA actually issued a warning about increased risk of cardiovascular events with varenicline. There was a meta-analysis done after that clearly demonstrated no evidence of increased cardiovascular events. And so there's no concern about cardiovascular risk with varenicline. And of course, the benefit of quitting smoking is also very important. So we don't really have to worry about those two controversies. And so finally, with varenicline, it doesn't really have drug interactions, which is nice. It does have a few side effects, which can be limiting for some patients. And so nausea is a big one. So up to 30% of patients experience this. It's recommended to take it with food and a full glass of water, and that sometimes will help. Some patients can get insomnia. So taking the dose at breakfast and supper is usually helpful. And then it causes vivid dreams for most patients. So honestly, most patients will get vivid dreams. So for some, those are just kind of fun or entertaining. And for others, they can be scary. So really, we just want to make sure we warn patients about that. Okay, so probably up to this point, a lot of what we've discussed has been review. But now I'm going to get into kind of some of the things that are changing in this area. So the first kind of emerging trend, I guess, is e-cigarettes, also known as vaping or vapes. So chances are you're familiar with these to at least some extent. It's, often you'll see somebody vaping when you walk down the street now. So what an e-cigarette is it's an electronic device that looks kind of like this device in the picture. Now, this is a first generation one that actually they made them look like cigarettes. They don't look like this anymore. So they often look like some sort of almost USB stick, usually a bit larger than that, but same kind of components. And so this picture illustrates it well. And so what it has is it's got a battery and then a heating element, and then a liquid, which is also often known as the e-liquid. And so that heating element will heat that liquid and it creates a vapor. And so the user will inhale that vapor. So they are inhaling nicotine within that vapor. And there's other components too. So things like propylene glycol, glycerin, that can be flavors or other chemicals or impurities. The key here is there's no tobacco in an e-cigarette, and it also does not involve any combustion or burning. So its heating creates a vapor, doesn't create smoke. So we looked at stats for smoking. We also want to look at what vaping rates are like. And so actually the most recent data we have is both 2019 and 2020, which it was 4.7% in both years. So call it about 5% are currently vaping in Canada. And so what's interesting, of course, and you probably could have guessed this, is that younger age groups are vaping to much higher degrees than older age groups. So much so that if you look at 2020, in under the age of 25, more people are vaping compared to smoking. And so although we're seeing this higher degree of vaping, we are seeing kind of historically low smoking rates in the younger age group. So we would prefer that people, of course, do neither. But as we're going to discuss, there is a risk difference between vaping and smoking. And so this difference is a positive, I guess. If young people are going to do one of the two, vaping is the lesser of two evils at this point. And so the first question that comes up is, do e-cigarettes work for smoking cessation? So just as a cessation aid, we know that those three first-line options are not effective for everybody. And so could somebody use an e-cigarette to help them quit smoking? And so we do know that based on kind of a number of different randomized controlled trials and systematic reviews, that there is evidence that e-cigarettes can provide effectiveness as a cessation aid for effective smoking cessation. Usually it's going to be for patients or people that are smoking tobacco on a daily basis. What's important, though, is anyone that is going to try to use e-cigarettes to quit smoking tobacco, they should try to switch completely to the e-cigarettes. And the reason is the risk of cardiovascular disease from cigarette smoking is nonlinear. So that means that even if you smoke only one cigarette in a day, your cardiovascular risk is half of somebody smoking 20 cigarettes in a day. So if someone's going to switch from conventional cigarettes to e-cigarettes, they should switch completely. Now, additional considerations are there's no real evidence for one device type compared to another. And really, it's just as long as the cigarette contains nicotine, which generally they all do at this point. Now, what we're really probably most interested in is how do e-cigarettes compare to conventional cigarettes when it comes to risk and harm? And again, we're talking about comparing e-cigarettes to conventional cigarettes. So not comparing e-cigarettes to nothing, right? So that's an important thing to differentiate, because we know how harmful smoking tobacco is and how harmful conventional cigarettes are. So we want to understand, how do e-cigarettes compare? E-cigarettes are not considered safe. You are still inhaling something. And so that's why, again, we have to just point out that it's a comparison between conventional cigarettes and e-cigarettes. So the first thing is cancer risk. And so Public Health England has done a lot of work on looking at all of the data available on e-cigarettes and trying to compare how that data compares to conventional cigarettes. And so they looked at the cancer risk and they estimated what they call the cancer potency of e-cigarettes compared to conventional cigarettes. And they estimate that the cancer potency is somewhere is about 1% of conventional cigarettes. And the reason they have to do this estimation is e-cigarettes have not been around long enough to determine what the actual cancer risk is. So this is an estimation, but really the estimation shows that e-cigarettes seem to have a much lower risk of cancer compared to conventional cigarettes. Again, not zero risk, but just a lower risk. The cardiovascular disease and lung disease comparison is much harder to make. So Public Health England can't really quantify it based on the evidence that is out there, but it's believed that the risk is lower than smoking. So that e-cigarettes would have a lower cardiovascular disease risk and a lower lung disease risk compared to smoking. And so Public Health England has been reviewing this evidence for a number of years, and they've come out with a statement that they just reviewed again last year and confirmed that it's still valid. But that statement is really for health professionals to try to describe the difference in risk between conventional cigarettes and e-cigarettes. And so Public Health England recommends that health professionals use the following statement. So stating that vaping is at least 95% less harmful than smoking is a good way to communicate the large difference in relative risk. And so they're basically saying you can be confident there's enough evidence that if somebody switched completely from smoking cigarettes to e-cigarettes, they would reduce their risk by about 95% or 20 times risk reduction, which honestly is incredible when you think about some of the risk reductions we see with different drug therapies. And maybe this is too good to be true, right? This is an estimation, but you can be confident, even if it's 90% or 80%, it's a risk reduction. And that's what's really important. So we do really have enough evidence to say that e-cigarettes are less harmful than conventional cigarettes. Now, this comes with a few caveats, right? So the long-term health effects of e-cigarettes are not known, right? So this is based on kind of short and medium-term data. There is, of course, substantial evidence that e-cigarettes with nicotine are addictive, and their use will likely result in dependence if someone continues using them. There is a concern you often hear that is e-cigarettes could be a gateway to using conventional cigarettes or tobacco. Now, this is a concern that is really theoretical, so it has not been substantiated. And we also know that in addition to the nicotine and that addictive concern, there is negative health outcomes associated with e-cigarettes, right? So people experience cough, mouth and throat irritation. There could be pulmonary and cardiovascular effects as well. One of the things that comes up repeatedly and people have heard a lot about is EVALI. So EVALI stands for e-cigarette or vaping associated lung injury. And you often hear of popcorn lung, which is kind of a component of this. And so a large number of these E-Valley cases were popping up, mainly in the United States, where patients were experiencing shortness of breath, cough, chest pain, fever, nausea, vomiting. And it was believed to be linked to e-cigarettes. So it was a massive concern because, of course, there was thought to, okay, this could mean that e-cigarettes are even more dangerous than smoking. And so in the recent years, this has largely been kind of narrowed down. So they found that E-Valley cases are really largely related to vitamin E acetate, which was a component of a number of THC containing e-cigarettes. So they have e-cigarettes for cannabis as well. And so that's what these e-cigarettes were. And so there is not enough evidence to say for certain that 100% of the E-Valley cases were from this component. But so far, based on kind of what's the evidence available, it seems that it was this vitamin E acetate from these THC containing e-cigarettes that really caused the E-Valley cases. And this is kind of confirmed because most of the E-Valley cases were in the United States. So there's a large number of people that use e-cigarettes in England and the UK, for example, and there really haven't been any E-Valley cases there. And so it was kind of puzzling because, of course, if it would to be linked to all these cigarettes, then you should see it everywhere. And so at this point, it's just kind of being monitored. But what's recommended for patients is if they are going to use e-cigarettes, whether for quitting smoking or to reduce risk from smoking, or even if they're just doing it because they choose to, that they should use products that haven't kind of been modified in any way and where they're not adding anything to them. So, for example, one of the things that comes up with these cigarettes is there are both closed and open tank systems. So closed tank systems are where a person would buy the e-cigarette. The liquid is not, you can't modify the liquid in any way. So you would, inhale that vapor. That liquid is kind of coming directly from the manufacturer. And then the open tank system are where the person or the user is actually adding their own liquid. And so they might purchase that liquid, but they can also modify that liquid. So they'll add their own liquid or this purchased liquid to the e-cigarette. And it is believed that those open tank type systems are largely related to these cases as well, because additives can be added to them. So if somebody is going to use an e-cigarette, they should likely use a closed tank system because it at least can't be modified in any way. And so if it's licensed and regulated in Canada, then it would not contain any of these components of concern. Okay, the second type of newer product that I wanted to talk about is heated tobacco products. And these are less well known or heard about compared to e-cigarettes. They're also known as heat not burn products or non-combusted cigarettes. They are really the same thing as an e-cigarette, except they contain actual tobacco. So rather than heating a liquid to create a vapor, they will heat tobacco to create a vapor. So the whole idea with these is we know that most of those harmful substances come from burning or combusting tobacco. So maybe if we just heat the tobacco and create a vapor instead of creating smoke, there could be less risk to the user. So this is a picture of one of the types of products. And so you can see it's got a battery, it's got a heating element, just like an e-cigarette, but the user places a tobacco stick into the device, which just looks like a really small cigarette. And that knife will cut into that tobacco stick. And then once the device is activated, it will heat it and create that tobacco vapor. And so there's a few other types of devices, but they all are kind of similar to this in the sense that they just involve the heating of tobacco to create a vapor instead of the burning of tobacco to create smoke. So, of course, the question is, This sounds like a good theory, but are they actually safer than conventional or combusted cigarettes? And of course, we have to reiterate there's no safe tobacco product, right? So this is still tobacco. It's definitely not without its own risks. But there is what's termed moderate evidence from shorter term studies, because these products are very new, that if a person uses heated tobacco products compared to conventional cigarettes, they will reduce their exposure to some, not all, but some of the harmful and potentially harmful compounds found in cigarette smoke. And so the FDA actually recognized that there is enough evidence to show this, and they've allowed one of these types of products to be marketed as a modified risk tobacco product, which is the first time this kind of terminology has been used. But the FDA said that there's enough evidence that this product system can be marketed with claims that fully switching from regular cigarettes to this system can reduce a person's exposure to harmful chemicals. So there, when the FDA's kind of reviewed the evidence and said there's enough to show that there's a reduction in exposure to harmful chemicals, then, you can be pretty sure to trust it, of course. The manufacturer cannot make any claims about risk of disease or that it's endorsed by the FDA because, of course, this has not been demonstrated in any way. The other potential benefit of heated tobacco products is secondhand emissions. So we do know that the secondhand heated tobacco emission is not as safe as clean air, but studies have shown lower levels of harmful substances in heated tobacco vapor compared to tobacco smoke. So it does have a possibility of reducing secondhand exposure as well. There does need to be more study and more evidence in this area as well. Finally, on heated tobacco products, a Cochrane review was done in 2022, and there is no evidence yet on smoking cessation. So we don't know if these products are really effective for smoking cessation. But the Cochrane review reiterated again that there's moderate evidence that they can lower exposure to toxins and carcinogens. There's also observational data from Japan. So in Japan, these products have kind of really been embraced, and they're seeing a record decline in cigarette sales. And so there's a thought that if these products are adopted, there could be kind of widespread reduction in smoking prevalence. So the Cochrane review kind of notes that what's come out of Japan is positive, and just more information and evidence is going to be needed. And finally, the kind of last, trend I wanted to talk about was smokeless tobacco. So you've probably heard of smokeless tobacco. It's been around for a long time. And that's just where a person puts the tobacco essentially in their, mouth or their cheek and absorbs it through the lining of their mouth rather than by smoking it. It is non-combustible, which is positive because it doesn't create all those toxins, but we know that it's associated with a number of different oral cancers and things like that. Because it doesn't involve combustion or inhaling anything, though, it is considered lower on the risk continuum compared to cigarette smoking. Again, has a lot of risks, but less than cigarette smoking, although there's no safe level of smokeless tobacco use. The product that is interesting in the smokeless tobacco area is something called snus or Swedish snus. It's a type of smokeless tobacco very popular in Sweden. And why it's different is normally smokeless tobacco, like dipping or chewing tobacco, is produced using a fermentation process, but snus is produced under something called steam pasteurization. And so it has lower levels of carcinogens compared to other forms of smokeless tobacco. So if someone is going to use smokeless tobacco, Swedish snus is really the one they should use because at least it reduces exposure to carcinogens. There's another newer product coming out called nicotine pouches. So this has kind of hit shelves in Europe and likely will be in North America soon. They are just like what's shown in the picture. So nicotine pouches are these white pre-portioned pouches. They don't contain any tobacco, it's just nicotine. And so the user puts that pouch between their lip and their gum and then just slowly kind of absorbs the nicotine through their lining of their mouth. And so there's no combustion, there's no tobacco. They're really, to me, kind of a newer form of nicotine replacement therapy. However, they haven't been around very long, so they've just been out since 2018. And so they have a possibility of being a reduced risk option. But at this point, we don't have any independent testing on their effects. But if it's important to point out too, in Norway, they're actually being sold in pharmacies next to the nicotine replacement therapy. So I wanted to include this in the presentation because I feel like these, when they come to Canada, could actually end up in our nicotine replacement therapy area. Because really, when you think about it, it's the same type of product. Okay, so I'm going to wrap up now in the last, say 10 minutes or so and talk about harm reduction a bit. So harm reduction, as you know, refers to reduction in harm from a prior level. So most health providers are very familiar with this as it pertains to opioid use. So we know that things like naloxone kits, methadone, Suboxone, these are forms of harm reduction. But harm reduction has historically had very limited application in tobacco use, right? You've probably never even thought of the term harm reduction when it comes to tobacco use. So, as I mentioned kind of off the top, smoking prevalence in Canada is plateauing. And so there's now kind of this renewed focus on tobacco harm reduction because we have to look at different ways to help patients get that rate of smoking down further. So in 2022, CAMH, which is the Center for Addiction and Mental Health in Canada, as well as a couple of other groups, including Pharmacists for a Smoke-Free Canada, released the first ever lower risk nicotine use guidelines. And so these guidelines really looked at some of these newer types of products that I've been talking about and took all the evidence and said, well, how can you actually apply this to patients? And in Alberta, the province I live in, Alberta Health Services, our provincial health authority, released a clinical support document for all of their clinical staff about using e-cigarettes in a tobacco harm reduction context. So why is harm reduction important? Well, again, we know that the range of diseases from tobacco use are largely the result of that burning or combustion of tobacco. And so nicotine itself, again, very addictive, but if we can find ways to get people their nicotine without all that toxin and chemicals and carcinogens produced with the burning of tobacco, then it has the possibility of helping those that are just not able or not willing to quit smoking. And it's really about the health provider finding a way to meet a patient where they're at, right? So regardless of readiness to quit, still offering something to that patient. So how would harm reduction look? So again, I have to reiterate though, abstinence is always the goal. So ideally, we would have every single patient quit smoking. That would always be the goal and remains the goal. So this is not different. Harm reduction simply offers something for those that aren't at that point where they're ready to quit, or maybe they just haven't been able to do it. So if you think about schizophrenic patients, for example, we see 95% smoking rates in patients with schizophrenia. It's almost 100, right? So that population, as an example, can be very hard to be successful in smoking cessation. So harm reduction may offer an alternative to those patients, for instance. Examples of harm reduction are using nicotine replacement therapy different or off-label, so different than it's officially indicated. So that could be using it long-term, like more than 24 weeks, or using it in combination with cigarettes. using it when it's off label is technically a harm reduction approach. And we've been doing this with nicotine replacement therapy for a number of years. Other ways might be switching from smoking tobacco to e-cigarettes to reduce the exposure of toxins and carcinogens, or switching from conventional cigarettes to heated tobacco products to again reduce exposure, or even potentially switching from smoking tobacco to smokeless tobacco. Specifically, like we discussed, Swedish snus would be the preferred option there. The strategy of tobacco harm reduction does remain controversial. So opponents of the strategy argue that this could interfere with cessation and abstinence. And of course, there's a concern about an initiation of tobacco use. Supporters of the strategy, though, believe that lessening the health risk for the individual is worthwhile and will also manifest itself in kind of the population health with fewer tobacco-related illnesses and deaths. Really, wherever you are on the spectrum of if you're for or against harm reduction, to me, I just go back to the question of how can you ensure patient-centered care for those that are unable or unwilling to quit, right? So for many years, it's just kind of been like, come back and see me when you're ready to quit. We've had nothing to help those patients. And now we have enough data to say there is something we can do for them. So the key recommendations for e-cigarettes and harm reduction would, again, people who don't use any tobacco shouldn't use e-cigarettes. So people shouldn't start using something. But if a patient is not able to quit, not willing to quit, switching to e-cigarettes will reduce their risk. And again, patients should switch completely because of the nonlinear nature in cardiovascular disease. And the idea would be that if a patient switches to e-cigarettes from conventional cigarettes, hopefully they would explore a quit attempt from the e-cigarettes down the road too, right? So it doesn't mean that they can't progress further to lower their risk even further, but for some patients, they might need an intermediate step like this. Heated tobacco products, again, if a patient doesn't use tobacco, they shouldn't start with these products. The general idea is the use of these products should be discouraged because there is better data to demonstrate e-cigarettes are less harmful. But patient care always must be individualized. So if a patient is unable to switch or not able to switch to e-cigarettes, not able to quit, not able to switch to e-cigarettes, then switching to heated tobacco products will allow them to reduce their exposure to harmful substances and as well as second and third hand exposure. And so really, I'm just going to close on telling you a little bit more about kind of my story. So I've been a pharmacist for 12 years, like I said, and I've always been very passionate about smoking cessation. I've worked in this area since I graduated in 2010. And I'm really proud to say that I've helped many patients quit smoking over the years. But I have to admit that the majority of tobacco users that I've seen in my practice are not ready to quit. So I've always felt extremely frustrated by an inability to help these people. And over the last, 5 or 10 years, as the opioid epidemic continued to worsen, I really learned a lot more about harm reduction as it pertains to opioid users. And I would kind of find myself wondering, why is there not something like this to help patients that smoke, right? We've always had an all or none approach. And partly that was because we didn't always have the data that we do now. But now that we do have alternatives for those that, like I said, can't quit or won't quit. And so to me, patient-centered care is just about meeting a patient wherever they're at and just helping them be, as healthy as they can be. And so how this looks for me is if a patient is a conventional tobacco user, I would first try to help them quit tobacco use, right? That's always the first goal. If they were not ready to quit, not able to quit, then switching to e-cigarettes would be the next best option for them. And again, some patients aren't able or maybe interested in e-cigarettes, and that's where it might be worth exploring like a heat not burn product or even one of those smokeless tobacco products, again, preferably snus if somebody was interested in that. Whatever we can do to help them reduce their risk, to me, is worth it. And then again, hopefully in the future, you can explore a further quit attempt. And so I have the picture of the ladder because to me, a ladder approach makes a lot of sense. If you think about conventional cigarette smoking being at the top of the ladder and, someone smoking, inhaling nothing to be at the bottom, ideally we want patients to just jump from the top of the ladder to the bottom, but not everybody's able to do that. And so e-cigarettes are somewhere in the middle there, heated tobacco products somewhere in the middle there. If we can get patients to at least go down on the ladder and reduce their risk, then to me, that's a win and something that we should explore. So that's really what I had for you tonight. I'm certainly happy now to take whatever questions there are. And thank you so much for joining tonight.
Thanks so much, Todd. That was an excellent presentation, really good review and, highlighting what pharmacists can do. We've got quite a number of questions. So for whoever can stay, we'll go through your questions. The first one is a case question. So let's say a patient had received a course of Champix for 3 months over a year ago, 13 months ago, and successfully stopped smoking. And then they started smoking again recently with 1 to 2 cigarettes per day. What would your thought process be, Todd, and what would you recommend?
Yeah, I mean, I think in that case, it sounds like they were successful with varenicline. So they should probably, I would say, if they were willing to try it again, if they tolerated it and that kind of thing. Because a lot of the times what happens is people will take a cessation aid and they are successful. And then when a relapse occurs, 6 months or it's 13 months down the line, the medication's long gone. So there's other factors at play. So likely a repeat case or a repeat course of varenicline would make sense for that patient, I would think.
And in your practice, Todd, how often does relapse occur?
It occurs a lot, right? And the problem too is, you hear a lot of data. Okay, people need to try at least 7 times is often said to quit, but that's like probably drastically lower than it actually is, because patients don't always admit all of the times that they weren't successful. But unfortunately, it's a reality. And you do, like, when you start to work with more and more patients in this area, you'll see successes, but you also have to define successes, right? So sometimes you can be successful for a month or 2, and that's great. That's awesome. But you can relapse sometimes 3 months out, 6 months out, a year out. And so one of the challenges we have with all of the efficacy data with these drugs is that often the studies were 3 or 6 months in length. And so they didn't really look at people, say 2 years out, because unfortunately relapse can occur at any point, of course.
Right. So a bunch of other questions. So where can patients get e-cigarettes, or where can we direct them to get those safe products?
Yeah, and that's a great question, and it often comes up. And so really, I think the key is, like, where people buy e-cigarettes is usually vape stores or gas stations or convenience stores. They can also be purchased online. So the key is not as much where they're purchasing, is that they're purchasing products that are regulated and licensed in Canada. So you can buy products online and even in some stores that may not actually be properly licensed in Canada. And so that's where I talked about that closed or open system, for example. So generally the closed systems where the patient can't modify the liquid in any way, those generally can be trusted and usually are properly regulated. Some of the open systems are too. However, it's a bit more of a Wild West in that sense. So That's kind of the easiest answer to me, is to try to make sure they're going with something that's like a closed system, because you should be able to trust that it's properly kind of regulated by Health Canada.
Okay. And price-wise, Todd, how would have you looked at the price of e-cigarettes versus regular cigarettes in terms of nicotine content?
Yeah, so generally e-cigarettes are cheaper than conventional cigarettes. Um, it varies by province, but it's how much cheaper it is. The only downside to that, or caveat, is e-cigarettes are limited with how much nicotine they can contain in Canada. And so some patients that are very heavy smokers will find they need to use an e-cigarette frequently because they just can't get as much nicotine as they need. And when that occurs, they might use more. So the cost may be more comparative. But yeah, generally there's actually even a bit of a cost savings. So that's even another selling point.
Do you know if there's any coverage? That's a question. Is there any coverage for e-cigarettes under any programs?
There's not at this point. We could get into a debate of maybe there should be, right? Some countries that are really progressive, like New Zealand, for instance, they're actually have targeted high populations that have high smoking rates, and have actually provided e-cigarettes at no cost, and they're seeing like drastic smoking reductions. Like in the UK, if you're hospitalized and let's say you have a heart attack and you're a smoker, you'll actually be sent home with like an e-cigarette starter kit. And so there is progressive things happening, but at this point in Canada, we haven't quite got there where they're regulated or would be covered, I guess.
Mm-hmm. There are some questions, a couple of questions about, accessing e-cigarettes again. And it's an interesting topic, Todd, because in my head, almost, thinking about nicotine e-cigarettes, it's just like NRT, right? And we have those cartridges where it's like a little cigarette for Nicorette or whatever it is as an NRT. And so is there, maybe just speculative, is there room for pharmacy to take more of a role in that in the future, you think?
Well, I think there definitely is. I mean, there's a lot of there's a lot of issue with like how some of the regulation is on these reduced risk products. So in Canada right now, they're really all kind of lumped together. So for the most part, e-cigarettes and heated tobacco products are regulated the same as conventional cigarettes. To me, there should be kind of different buckets because they are reduced risk. We know people are going to use products, and so maybe there should be different options, because currently you can't really carry any of these products in a pharmacy. But there could be a role in my mind, because we know that pharmacists are the most accessible. We're having a lot of these conversations with patients, but that's one of the big challenges that always comes up when I do these talks. Is like, okay, I'm on board, I want to do this, but like I'm not really comfortable with sending a patient down the street to the gas station to buy something for that I'm recommending, right? So that is definitely a barrier, and something that hopefully we can make progress on as a country. But for now, of course, you are limited to kind of having some of these conversations, unfortunately.
Mhm. Is there any data, Todd, to show that, or has it even been looked at, where e-cigarettes increase the chance of smoking cessation down the line?
There is some data that they do, yeah. So even if somebody were to just switch, that they may successfully not smoke tobacco again. And part of it is like, how do you define smoking cessation? So is smoking cessation just not smoking tobacco anymore, or is it getting off like any form of nicotine, right? So because if somebody successfully transitions from smoking conventional cigarettes to e-cigarettes, to me they have quit smoking. I mean, now they're vaping, which is another thing, but it's a lower risk thing. So again, you still want them to stop doing that. And that's still the goal. But to me, at that point, they have quit. But there is data to show that a lot of people will switch to e-cigarettes and they won't go back ever to tobacco.
Great. And there was another question that came in about EVALI. So there's the mention of vitamin E acetate in THC products. Is there vitamin E acetate in some of these nicotine e-cigarettes?
Not generally, no. So you can't, it doesn't really work in a nicotine containing e-cigarette. So my understanding, I mean, I'm not an advanced analytical chemist or whatever you would need to be, but my understanding is that vitamin E acetate wouldn't really dissolve properly in like a nicotine containing liquid. So it's really something that's found in would be found or could be found in THC containing products.
Okay. And I think one of these questions that I missed around NRT and coverage. So Fora says main barrier is coverage for NRT other than STOP. Is there any other programs providing free NRT products that you're aware of, Todd?
Yeah, and I know Alberta only really for the provincial coverage, but I mean, there is some federal coverage, right? So NIHB, for example, I think Veterans Affairs has some program, but yeah, generally that is a barrier. I mean, some plans don't cover any of this stuff, like not only not NRT, but not bupropion or varenicline too, right? So it is definitely can be a barrier for sure. I would agree.
Excellent. I think that comes to the end of our questions. If anybody else has any questions, feel free to add them in the next minute or so. Thank you so much, Todd. I've gotten a lot of comments about how excellent this session has been and how refreshing this approach is. It was a great review for pharmacists and, really good introduction for e-cigarettes and some of the other modalities too that we can consider for our patients, especially around harm reduction. And I really like how you had framed it around how healthcare providers can think about it and what we can say and, essentially how we can support our patients where they're at, right? So yeah, thank you so much again. Thank you also to RBH for the support of pharmacy education in this space. And finally, big thanks to everyone who attended tonight and for everyone who will watch the recording as well. If there's no other questions, we'll let you go, Todd. But everyone who's watching, if you have any extra questions for myself or for Todd, I can pass them along. You can just email me. All right. Thanks so much, Todd. Have a great evening.
Thanks.
Thanks, everyone. Bye. Oh, there's a question. Where do we get access to the recording or the slides? I will send them out in the next couple of days. So don't worry, you can rewatch the recording. And Todd, with your permission, will circulate the slides as well. Thanks, everyone. Have a great evening.